evening to our annual general meeting of Hampshire Hospitals NHS Foundation Trust. For those of you who don't know me, I'm Liz Cadmore. It's my privilege to be chairman of Hampshire Hospitals, and I'm joined on the platform this evening by my executive team. So, in no particular order, Dr. Andrew Bishop, who, as you know, is Chief Medical Officer, Julie Massery, who's our Executive Director for Performance and Transformation, Donna Green, our Chief Nurse and Deputy Chief Exec, Mary Edwards, Chief Exec, and Malcolm Ace, who many of you won't know is our new CFO. So this is his first AGM for Hampshire Hospitals. So I'm sure you'll be nice to him. And a number of my non-executive colleagues I can see in the audience, and also a number of our governors, and thank you very much to the governors particularly and my non-exec colleagues for joining us this evening. It's always appreciated. I really hope you had fun in the first part of our evening with all those terrific exhibits that our staff put on. It's immensely rewarding, I think, to see the passion that they bring to their work, whatever that work is, and they freely give up their time to come and tell you all about it in the evening, and I just think that's a remarkable thing to do. I also hope you managed to get time to go around the chemotherapy van, the mobile unit for the chemotherapy, which we are able to provide thanks to the charity Hope for Tomorrow, and is much beloved, particularly in Andover, I know, but has also been very helpful for people in Alton and Eastleigh. And I know some of you, because I saw you there, had a very interesting behind-the-scenes tour of our radiotherapy unit, including bits that I've never seen before, and I've been around several times. So, again, the passion of our staff was wonderful to see being shown around. But I'd particularly like to formally welcome the Right Worshipful, the Mayor of Winchester, Councillor Jane Rutter. It's very kind of you to be here this evening. It's an absolute pleasure to have you here. As you'll have seen from the agenda, this evening is mostly now about reviewing our performance. I appreciate that it seems slightly curious to be here almost at the end of July and reviewing the performance of our year that finished at the end of March. However, we do have to do a certain number of things before we're allowed to discuss it with you, and that's why it has to be this time of year. Perhaps more interestingly, we're also going to talk about some of our plans for the future. And I'm particularly delighted that we'll also have a talk from one of our leading clinicians, Dr. Shaheen Dixon, who's a consultant radiologist here at Hampshire Hospitals, is going to talk to us about the innovative and leading edge areas of interventional radiology. I'm not sure if we can have a leading edge area of interventional radiology, but we might learn about it. I certainly know that it's going to be really interesting and informative, and I'm very grateful to you being here. And with good luck in the following wind, you should all be in your cars going home by 8:30. So we're now going to move to the main business of this evening, which is the review of last year and our plans for the future. We're going to present to you the highlights from our annual report and accounts, incorporating the auditor's report. Our performance last year was set against what one might say has been a uniquely challenging year for the NHS. As I'm sure you'll all know from reading the newspapers or turning on your news, up and down the country, we and other hospitals like us have faced severe financial constraints while needing to care for really very sick patients. Added to this, here in Hampshire, we've also seen many more acutely unwell, frail elderly people needing our care. And they then need the help of our partners in social and adult services, and this has been really challenging for the whole of the NHS. So, as I'm sure you will know, these pressures in the system have impacted on our ability to meet the national target of 95% for our emergency patients to be seen and treated within 4 hours. I just want to reassure you that it's not acceptable to us that we're missing that target, and it certainly isn't for want of trying. Our staff are working tirelessly at it. And we have made some improvements in the area, but it does still remain a challenge, and we're working really hard to address it. I very much hope that the next time I see you all will be back on track. We are definitely improving, but it's still very, very, very busy. But despite these and other pressures, and with great thanks to our hard-working, committed and compassionate staff, I'm extremely proud of all that they've achieved in the last year. As you probably know, we receive recognition for the high quality care we provide to our patients from the Care Quality Commission. They rate it as good overall. I'm probably pinching some of the best lines in my colleague's presentation, I apologise. But what really impressed me even more than that was that they judged the quality of care that we provide as outstanding, and isn't that above all what you really want from your hospital? And they also judged us outstanding, again, in all 3 of our hospitals for the care we give at end of life. And some of you may have talked to our palliative care team upstairs, they are terrific. So I would publicly like to go on record thanking our staff for achieving all of this. And they continue to be recognised in all sorts of ways. I mean, our governors will know that the WOW Awards now have become somewhat overwhelming to judge. We had 2,289 awards last year. That's just extraordinary. And earlier this month, some of you were at our Director of Nursing Awards. We received more than 300 awards, nominations again from members of the public for that, which is phenomenal to recognise our staff in this way. And it's the nurses, the midwives, the healthcare assistants, the porters, the housekeepers, everybody. As well as our Cqc report, there have been plenty of other successes that we've celebrated over the year, ranging from our hyperacute stroke service being named 3rd best in England and Wales, to our maternity services being awarded baby-friendly accreditation by UNICEF and the World Health Organization. We also, and I know this matters to quite a lot of you, we also became the first hospital trust in the south of England to adopt John's campaign, where we allow the carers of patients with dementia to stay with their loved ones at all times during their stay in hospital, and I know that that's made a big difference to a lot of people. Anyway, you will hear more about all of these from Mary and Malcolm shortly, and it is, of course, all included in our annual report and accounts. These accounts were approved by the board, laid before Parliament at the end of June, and presented to our Council of Governors on the 19th of July. A full copy is available on the website. It's not a light read. That's the size of it. I think there is a copy upstairs if you desperately want to look at all of it. But you may be pleased to know that we've also produced a summary report, which I think you've picked up, and also Donna's produced her own Chief Nurses Review, which again I think if you haven't picked up, you can pick up on the way out. But in any event, we're very pleased this evening to be able to share the headlines from the annual report and accounts with you, and Mary and Malcolm will now take us through that.
Good evening, everybody, and thank you particularly for those of you, I recognise many in the audience, who come and join us for this session every year very loyally. You've heard some of the highlights already from the chairman, so I'm going to whiz through some of that because I'm sure, like me, you'd rather be listening to Shaheen tell us about interventional radiology. So I'll do a very brief run through the performance summary and our CQC inspection and achievements in the year 2015-16. Malcolm's going to cover the financial summary and then also very briefly look at the outlook for the year we're in. So as the chairman's already said, we have continued to be extremely busy. Attendances in our emergency department, that's A&E to you and me, have continued to rise. And as the chairman's already said, sadly we have failed the 4-hour target. That's we're expected to see 95% of patients who arrive in the A&E, see them, assess them, diagnose them, treat them, and either send them home or admit them to a ward within 4 hours. And that's the target we've been struggling with during the last year. Some of that is because of the fact that we don't have enough beds to cope, that we've got enough capacity at any one time to make sure the bed's always available. And some of that is because we have got more patients who are taking longer to either get home with a package of care or into a nursing home or residential home. But we're working as closely as possible with our partners in the County Council Social Services, but also in Southern Health, our community care providers and our local GPs, constantly trying to find different ways of enabling those patients, firstly not to be admitted because often they don't need to be, and secondly, if they are admitted, to get them home as quickly as possible. Our planned services are very busy, but we are managing to hit those targets. And we have also managed to hit the targets like cancer targets and some of the infection targets like C. diff that you will hear about in the media. So although there's a lot of airtime given to not managing to hit the ED target, other than that, actually the staff have been delivering the other targets, and I think sometimes we sort of forget that there's a heck of a lot of what we do that people are still managing to deliver those performance targets in. As Chairman said, we had our CQC inspection last year, back end of last year, and we received an overall rating of good. We are the only organisation in Hampshire actually that achieved the rating of good. It's a very extensive inspection. We get 50 plus inspectors going in all 3 hospitals all over the place, and as you've already heard, not only did we receive an overall rating of good, but we got excellent for care and excellent for end-of-life care. So brilliant there. My reflections on the CQC report and the investigation was, I think first of all I'm absolutely delighted for our patients, because if you're expecting to have to come into the hospital for anything, the one thing you want to know is that basically the independent inspectors have said that it's a good organisation, and particularly that the care has been rated as excellent. So I'm hoping, sorry, I'm pressing my buttons by accident, I'm hoping that that is reassuring to our patients. I'm absolutely delighted for the staff because I think it is a really good justification of everything they do 365 days of the year, 24 hours a day. Despite what you might read in the media, we are open 24 hours a day, and there are doctors here 24 hours a day. Having said that, we're not complacent, we want to be even better, and there are some areas for improvement that we're going to work on to try and make that even better. And just to give you a flavour of things that we need to look at, we had a number of issues that the CQC identified. We had already identified those and were working on them. And the really good news is the ones with the tick we've already resolved. We've got a couple of things that we still need to improve, and we actually need help with those. So the first one, CAM, stands for Child and Adolescent Mental Health Services. So there is a nationwide problem in accessing speedily the right sort of very specialist mental health services for young people who have sometimes quite profound mental health problems. And Hampshire is no different to anywhere else. It is really difficult sometimes to access the specialist expertise. It doesn't sit in our organisation, it's in a partner organisation. And so we're working with that partner. It's actually an organisation called Sussex Partnership to try and improve that. And sustainable staffing plans, there's an awful lot behind that, but the short answer to that is, in order to make sure we've got enough, particularly the very specialist doctors, available 24 hours a day, we need to centralise our services. A lot of you have been on this very long journey, you know the story. So we want to centralise the care of the sickest. In that way we can have enough consultants and other specialist staff available on a rota 24 hours a day to make sure that if someone is really ill, they get consultant delivered treatment whatever time of day they're taken ill. So things like heart attacks, strokes and so on. And so the story about resolving that problem is still waiting because it is dependent on the ability to centralise. And again, I know a lot of you know this, our plan would be to create a critical treatment hospital to do that. I whizzed through one slide. I've already mentioned the care and end-of-life care, but other areas that the CQC were very positive about was our dementia care. And hopefully some of you met the team upstairs who really spearhead that work for us. And they really are fantastic, and they've introduced lots and lots of changes across all of our hospitals so that we are better at supporting patients and their families with dementia. And also they recognise the fantastic clinical leadership we have across the whole organisation, and I was quite proud of that. And last but by no means least, I can't obviously ignore the fact we do have some quite specialist surgical expertise. So things like our pseudomyxoma service, our liver cancer and colorectal cancer services were recognised. Areas that we're still working on, things like making sure still that everything is standardised across sites, making sure there is no lack of standardisation in terms of systems and processes that should be the same, making sure that there's enough leadership support to remote services. That's particularly an issue, for example, in Andover. It's a smaller unit, and we need to make sure that the management effort is provided in the same level in Andover as it is in Winchester and Basingstoke. And also the old chestnut, we know we're not brilliant at this, we know we need to keep trying to improve, which is we still have a tendency to cancel your outpatient appointment when you're expecting it to happen. And we are looking at how we can minimise the impact of that. Areas for joint work. The first one, improving our emergency pathway in and out of hospital. That's what I talked about at the beginning, which is how do we make sure that very sick patients get in, seen, treated acutely as quickly as possible. But also for the frail elderly, either how do we prevent them needing to be admitted, so how do we support them outside the hospital, or if they do get admitted, how do we make sure we get them into a bed quickly and looked after in the appropriate facility, not waiting too long in the emergency department. The second one I've again already mentioned, which is how do we make sure we've got the right expertise in the hospital for those patients who come in either with a mental health problem or with a learning disability. We've done an awful lot of work on the learning disability one. We still struggle sometimes again with provision both for adults and younger people who might have an acute mental health problem, and because we're probably the only part other than the ambulance service that's open 24 hours a day, often patients are brought to us when actually their need is for acute mental health, psychiatry, etc. And we don't have that specialist care in our teams, and we are reliant again on our partners in Southern Health for that. And I've already mentioned the clinical staffing. Some examples of improvements and developments in the year. Again, I'll whiz through these. You've heard about some of them. So delighted that our stroke unit was recognised third best in equal third best in England, and certainly the best in Wessex. And that's for the very acute treatment when the stroke's first happening. We have developed more services to be available 7 days a week. So, for example, pharmacy support, some access to routine scanning. We've still got some more to go there, so don't think everything is available yet 7 days a week, but that is what we would like to do. We've shared the learning we made in Winchester, actually, and we now have self-check-in services. May not float your boat, but there's gadgets you can see on the right-hand side where you check yourself in when you come to outpatients. We've opened a surgical assessment unit on the Winchester site. The idea there is that you may have an acute problem, come into A&E, ED, but your problem is surgical. You're actually better off being moved to the surgical assessment unit because then the surgeons can get to you more quickly and identify what's going on and what needs to happen. Our shared service with Hampshire County Council, Furvale, which is actually just on the back here in Rooksdown, is a specialist service to provide respite care for very disabled children, and that was rated outstanding by Ofsted, which is a major achievement by the staff. We became a corporate member of the Basingstoke and District Disability Forum, which has lots of benefits for us. We can learn how better to support people who come into hospital who may have a disability, but also we can use the forum to seek ideas on how we would improve things across our hospitals. And one that's probably only of interest to me actually, but that is quite exceptional, that we have clinicians who are party to research trials that are happening worldwide, and we actually recruited the first patient in the world into 2 trials. That is quite unusual in an organisation like ours, so I'm quite proud of it. Some staff successes. We had the Midwife of the Year, which is fantastic, not only because she was Midwife of the Year, but the reason she achieved it is she's the only midwife, I believe, in the country who has specialist expertise in supporting women with epilepsy when they're going through pregnancy and childbirth. And the lady who nominated her, the mother, actually came all the way from Essex because she'd heard about her expertise and wanted advice through her antenatal care. and she reflected that her birth experience was so much better from having had the support of Kim Morley, our Midwife of the Year. Our military attachment programme, again, you may have seen some of the individuals upstairs, our former military employees who are now employed within the NHS. They've helped us develop a liaison with the military where it's much easier for people as they're departing the armed services to consider and access jobs within the NHS. Brilliant for us because we get fantastic new people in, but also brilliant for them because they don't have to sit there thinking, I wonder who's going to employ me. And they are phenomenal employees in all sorts of different roles, some clinical, some admin, some managerial. And last but by no means least, Donna has enabled us to be the first in the country to introduce the new concept of a clinical matron. Some of you I know are former nurses and will know exactly why this is important. But having the most experienced clinical people actually stay at the coalface on the wards and in the departments, delivering clinical care at the same time as being a role model and a leader within that clinical area is a huge benefit. It's how the doctors have done clinical leadership over the years, and for whatever reason my profession felt that you had to stop being a nurse and become a manager. And I think what Donna's done is bring that back and keep those really, really, really experienced clinical people looking after patients as well as doing the leadership. So that's phenomenal. I'll move on now and let Malcolm do his first presentation on our finances. Thanks, Malcolm.
Thanks, Mary, and to repeat the welcome and thanks for everyone coming. It's a huge privilege to be speaking to you tonight. No pictures on this because it's not quite as happy a picture as the one that Mary painted, but it is all of a piece. Last year was tough for the Trust, a lot of real pressures on the Trust, and within that environment we delivered a deficit of £6.9 million for the year against a planned deficit of £2.1 million. This isn't an excuse, but it's really important context. 65% of all trusts, all provider trusts across England produced a deficit last year, and the total of the NHS provider deficit was £2.4 billion when it was estimated at the end of December, remember we have a March 31st year end, to be £1.8 billion. So there was a deterioration, not just a deterioration from a rough balance to £2.4 billion, but a deterioration of 600 million on people's forecasts in the last quarter of the year. This Trust delivered the deficit that we predicted at the end of December, by the end of March. Huge amount of hard work to be able to do that at the time of greatest pressure with attendances to accident and emergency and other issues compounding within the Trust. So very important that we kept to that revised deficit plan that we submitted at the end of quarter three. That gives a credibility to the Trust and the management of the Trust, and I can say that without self-consciousness, as I wasn't part of it then, but well done, because that was a really important aspect of it. Our income for the year was just about on plan. There were ups and downs in different clinical areas, but we just about achieved our income target for the year, and our expenditure, an increase in expenditure was what drove us away from our plan, mainly driven by pay costs, which were up 5% on our planned total and up 5% also on the end result for 2014-15. These were driven by all the pressures that Mary described, greater employment of agency staff and also an increase in our substantive staff. Our cash over the year reduced to 8.5 million. It's reduced further. I'll explain that when I come on to my next but one slide. But to end the year with £8.5 million of cash and a turnover of £350 million, it means that we've got about 9 days turnover in cash terms. That's that feels very, very uncomfortable to me and uncomfortably close to the edge. We spent £11 million of capital last year. and our borrowings increased by 9.5 million. So really we had to borrow most of our money to fund our capital plans last year. We ended the year with a financial sustainability risk rating. This is a risk rating that's calculated on a small number of financial metrics by Monitor, as they were then, NHS Improvement as it is now. That was a risk rating of 2. It's a 4-point scale where 1 is perceived to be the greatest risk to financial sustainability, 4 is the least risky to financial sustainability. But again, to put it in context, out of 151 foundation trusts, 19 trusts were rated as a risk rating of 1, 71 trusts were rated in the same risk rating as we were, 2, and only 61 trusts were rated as 3 or 4, which is quite an extraordinary position, that around about 40% of foundation trusts are rated 3 and 4, and 60% are rated 1 or 2 in this financial risk rating. I think that shows the pressure across the whole NHS system. These are some longer term trends to pick out of the trust. And again, the interesting bit about the income is that we've lived through a period, all trusts have lived through a period where there has been very substantial real term reductions of our the price we get paid per patient for those procedures. The income within the trust has increased over those years because we've just been doing more activity. That is a pressure that is again felt throughout the NHS, and you can see that even with that real terms reduction year on year, our income over those 4 years has grown slightly. Our costs have grown slightly quicker, despite the best efforts of the trust to keep a lid on these, and our cash has decreased markedly over that period. Again, I think that this is a fairly typical picture for most trusts within the NHS who are still within a manageable financial regime. You will see, I'm sure, in the newspapers, a lot of trusts have gone beyond a financial manageable regime, and this trust is still very much in control of our finances. I think it is slightly more positive looking forward to the new year, to the current year rather. We have a new stream of funding which has been introduced by NHS Improvement at the beginning of this financial year, the Sustainability and Transformation Funds. That will give us £10.3 million if we hit all of our targets, both financial and clinical, over the year, but we need to achieve our financial target to be able to access that. Our financial target for the coming year is £6.4 million surplus, which is going to be tough, but for the first quarter of the year we've hit those targets. We're slightly ahead of those targets, but it is going to be a very tough target to achieve. And again, to put it into context, while we're we're planning to make a surplus of £6.4 million, the overall NHS provider deficit, the aggregate of all the provider trusts in England, is a deficit of £580 million, and over 100 trusts are predicting a deficit. So we're in quite a select band of trusts that are predicting a surplus for the current year. Our big challenge in the next few months is to substantially reduce our agency staffing bill. There are lots and lots of good reasons for that, both financial and in terms of patient care, and we're doing everything that we can to do that, but again, within enormous pressures on our services. We have a cost improvement plan. To be able to achieve our plan, we need to make savings of £11.5 million in the current year. Last year we made savings of about £11 million, again that's very achievable. But again, just to counteract some of the negative publicity of the public sector and the NHS. Across the UK economy, productivity has probably been flat for the last 7 or 8 years. The NHS is expected to make productivity gains of 2 to 3% a year. We do this, we might not hit the absolute target every year, but every year, year on year, the NHS becomes more productive. We have a very tight capital programme in the coming year. It's really a care and maintenance programme with very little scope for further investment. And again, it was great to talk to some of the people upstairs on the stalls promoting the work of the charities, because that is becoming really important in terms of generating funds for new equipment for the Trust. And we're aiming to end the year with a risk rating of 3, which would take us probably, as I described before, into the top, certainly the top half and possibly the top third of trusts in terms of risk rating from our regulator. We're going to finish the last couple of slides there.
Thanks very much, Malcolm. It was really interesting. So again, very last few slides just to close up. Outlook for the year we're in. Our long-term strategy is still very much what we want to do, which, as I know a lot of you know, is about centralising the care of the sickest or the most at risk. That's about 15% of what we do, and then build up the local services in partnership with local GPs, our community providers, social services and so on, so that we can provide more care locally. It's about 85% of what we do, but also potentially actually avoid the need for people to come into hospital at all wherever possible, and then developing this critical treatment hospital where patients are taken by ambulance if they're really ill, consultant delivered treatment there, which shows you get better outcomes, plus where we'd have high risk maternity care, and then develop the local services alongside that. So that very much is still what we want to develop locally. The other things we need to do in the shorter term is actually make sure we can cope with the pressures we've got at the moment of patients coming through the emergency departments, the A&E, and getting that flow through the hospital so that patients are not waiting too long in the emergency department. As Malcolm's already said, we've also got yet another tough ask in terms of bringing down what we spend across the place. And some of that is how do we get more efficient, and a lot of the work that Julie's involved in is saying how do we transform things so it's not arbitrary cut money, but actually how do we use our money better and get more work done through the resources we've already got, most of which obviously is people, and how do we become more efficient in how we do things. And then last but by no means least, and I hope this doesn't sound trite, but we can only do this through our 6,000 people, so we have got to keep developing those people. We've got to recruit them, and then we've got to retain them. And one of the things the NHS constantly, and we're as guilty as ever, is not good enough at, is retaining the people. And that's what we've really got to focus on in these tricky times. So in conclusion, I think we've probably convinced you it is quite challenging in the NHS at the moment, and we're no different, but we really do want to make sure we're maintaining high standards where they exist already and where they don't, improving them so that it's high standards across the board. And I'd like to close by a huge thank you to our staff, to our governors, and also my fellow colleagues on the board. Thank you all very much.
Thank you very much, Mary and Malcolm. So if anybody wants to ask a question, raise your hand and the mic will find you, gentlemen over here.
Yeah, I see delayed discharge is still a big issue for you. Can you put a financial figure on how much it costs you to do that? I've read in the annual report that you've got increased staffing costs, you've been having more beds, etc. Do you know overall how much it costs?
So it's an interesting question. We have approximately about 70 patients at any one time in our hospital beds, which is equivalent to 2.5 wards per annum in terms of delivering the services on those wards in terms of staffing those wards, especially at the moment with the premium rates. It's about 1.5 million per ward in terms of running those wards. So that kind of gives you a feel of the sort of cost pressure, and then on top of that there are agency costs and premiums associated with that. So that's part of our challenge in terms of how we're employing, the cost and staffing costs of keeping those areas open.
Yeah, there's also an opportunity cost, because those patients we could be using those wards in different ways if we were using them. I think Julie's figure of probably if it's 2.5, 3 wards, that's probably costing us £5 million.
Yeah.
Okay, gentlemen, agree with that?
In your figures for the 5 years or so that you showed, I think it was 2013-14 showed £48 million coming in from other sources, which was noticeably higher than the previous year, noticeably higher than anything we've achieved since. What were we doing in that particular year to generate the extra £8 million?
This is John Haynes.
So some of the allocations of expenditure has shifted between the years. Expenditure which was Cancer Drugs Fund was outside clinical income in 13-14, now it's in clinical income. So it's a classification rather than a real issue.
We've all learned from that.
It was a good thought though, because we could find something else. So yes, anyone wants to buy a lottery ticket and share the winnings, I'm very grateful. Gentleman Kip?
You see it, trying to centralise your critical care. What's the situation regarding these CTH? What's stopping you getting on?
Andrew or Mary?
Mary.
Take that.
Mine will be less polite.
Okay, doctors are always there when you need them. So our recurrent problem is seeking support from our commissioners. So some of you will be familiar with the jargon, but clinical commissioning groups. They're the people who receive the money to buy healthcare, and they pay us to deliver it. And what we've been doing is working with them to convince them that the Plan A doesn't add costs, because their concern is we're going to need more money if we build this hospital. But also, I think there is a belief in the system that will create more beds and more work and so on, and that should be done closer to home. Actually, our plans are for 200 beds less than our current number of beds in the new system. So we are very much committed to delivering more care either at home or in nursing home, wherever is appropriate for the patient, and not getting the patients coming into hospital, and also when they do, getting them out quickly. And that translates roughly into about 200 beds. So if you imagine at the moment we've got about 900, 950 beds, it varies. And in the future world we'd have about 720 beds. So that's the comparator. We're still trying to persuade our commissioning colleagues that that is genuine and that we're not seeking more money, and that we are looking to reduce the beds in the system.
Gentleman, just in the middle.
Hello. We've seen a massive regeneration of houses being built both here and in Andover.
Yeah.
How much of a restriction is that placed on the hospitals?
I wouldn't say it's a restriction. I think what it makes clear to us is that we need to do something fairly innovative and strategic to cope. So Basingstoke alone, we're looking at a growth of 40,000 in population over the next 10 to 15 years. I'm afraid off the top of my head I can't remember the number for Andover, but it's an equally big number. So if you take our current population, and we're bulging at the seams, and that big growth, we've got to do something pretty fundamental in North Hampshire to cope with all of those extra people. And what the critical treatment hospital does is help us unlock at doing things differently. Because if we can create this really, really hot place that's really efficient and very fast, so you're in on an ambulance, you're off quickly, treated quickly, and therefore more likely to get home more quickly, that all is more efficient. And then we can reduce the scale of the operations in Andover in Basingstoke and Winchester, because those patients won't need to stay in the beds for as long as they are at the moment. I hope that makes sense. that gives us a chance to cope with that increase in the population, which, as you say, is very significant.
I've often read about the fact that you can't get people home because the facilities at home aren't ready for them. I have often wondered whether we as a hospital shouldn't have our own nursing home. I mean, how much does it cost per bed to have someone in that sort of level of care than to have them in an acute ward? Should we not have our own system? And you'd also make a bit of money out of it, like I hope you are out of the Candover Clinic, which I have used and it's brilliant. And is that something you've ever thought of doing?
Thank you for the plug, and I'm sure it won't surprise you to know that it's a conversation we have often at the board. But Donna, are you going to do that one?
Yes, over the years we have considered, and in fact on this site particularly, we've had some well-developed plans in terms of building a nursing home. I think it's become more complicated, certainly in recent years, in terms of the complexity of the patients, the standards for nursing homes, and we've also explored about doing a joint venture with partners as well. Unfortunately, contrary to popular belief, nursing homes aren't a great money maker anymore because of the standards and the complexity of some of the patients. So we're continuing to think about how can we support our patients to go home, work with partners. But if an opportunity came up that was favourable for both our patients and for us, we'd certainly be interested in it. At the moment, it doesn't look as if it's going to be a huge money spinner. Not that that's the only reason to do it, but it would be helpful.
I noticed that you talked about reducing the amount of agency staff, the amount of money you spend in getting them. I would like to know what alternative have you got in mind if you want to reduce, because in the immediate atmosphere that it is now, I don't know how easy it's going to be to get to recruiting direct staff to replace those agency staff that you're trying to reduce, the reduction of agency staff. How you're going to make the shortfall in bringing more people.
Thank you very much. Good question. Donna.
Yeah, it's a really important question, and those of you who've known us for a while will know that actually we were the only trust in the country who didn't use agency staff for very many years. And unfortunately our situation, not just in nursing but in some of our other specialist areas, is starting to struggle. And for safety reasons we've reluctantly gone to use agency staff, but what we try and do is use regular people rather than sort of having different people every day. So our plan is that we really need to focus on recruitment, and that's a combination of local people and people from further afield. We had anticipated this probably about 18 months ago and had been very proactive in terms of recruiting to the Philippines. Unfortunately, as many of you will have read and heard about in the media, we were restricted slightly from some of the Home Office restrictions. And I was talking to somebody earlier on today about, the impact of Brexit, and we're hoping that that isn't going to have a huge impact on us. We don't expect it will be at the moment. So it's really for us to do two things. One is about making sure we're really good in recruitment, and as Mary said, making sure that we develop and support our staff so that they stay with us as well. We do have to become more competitive in terms of our offer, particularly as we're near London and the difference in terms of wages. And then there's also something about being creative as well. So you'll see in the Chief Nurse Review, we're actually doing some really good things in terms of new roles and thinking about where it is difficult to recruit, where can we utilise other skills and experiences. And then finally, particularly for nursing, we're actively trying to support our students to continue to work with us and also see whether we can get people to return to practice. So it's a combination of all of those things, but it's also being constantly on it, because once you've recruited, there's natural attrition, which is also good for professionals to move on. So we need to be actively recruiting all of the time. That is challenging at the moment, but I think some of the steps we're putting in place, and if we can get our staff to enjoy working with us and be proud of the services we provide, I think it's probably an easier win than it is in many other places.
Question on the finances. You were giving us an idea as to how much it costs for people staying in for longer than they perhaps need to. Did we suffer with the backlog there in terms of what we read about being fined for missing targets? And what happens to that money?
Yes, we did suffer fines last year. The regime in the current year is that fines for virtually all of the fines for missing clinical standards have been removed. However, if we do not hit the clinical standards, then we lose the part of the transformation, sustainability and transformation funds that I alluded to, part of the £10.3 million. So, for example, on the ED performance target, the 4-hour wait, there's around about £100,000 per month that we will be paid if we hit the target and we hit all other targets. If we don't hit that target, we won't be paid that £100,000 in this current year. The fines last year went back to the NHS, to the Department of Health, the commissioners. To commissioners.
To the bottom line.
It's a very good question, because if you were dropped down from Mars, you'd wonder why one part of the NHS is finding another part of the NHS. It doesn't make much sense, as it just keeps, no disrespect intended, lots of accountants in business. But it is a bit barking mad. The original idea was that the fines would be held and reinvested in the organisations in order to help them fix the problem, and I'm afraid that didn't happen. So, sadly. Anyway, hopefully the future will look brighter.